We have some cases here, and we use the panel to look at cases. We have 15 minutes for cases, which I looked at. Okay. And you'll see the cases are virtual cases. So these cases modify certain features, and I'd like to get your and the panel's input about what is the right answer. When you look at the answers that will be provided later as options, there's not one single answer that's correct. Okay, we'll talk about a 35-year-old male patient diagnosed with stage 4 sigmoid, meaning left-sided cancer, synchronous unresectable lung metastasis, good performance status, no real tumor-related symptoms, no bowel obstruction, is screened for mismatch for protein expression levels, absence of MSI-H, MSI high, then it is a Lynch syndrome with germline mutation, no RAS or BRAF mutation. So that's a young male guy, metastatic disease, Lynch syndrome, no tumor-related symptoms. Okay, so what's first-line therapy you look at? So we have a left-sided tumor. Use FOLFOX or FOLFIRI-Bev. Use FOLFOX or FOLFIRI plus an EGF antibody. FOLFOXIRI with or without Bev. Use pembrolizumab, nivolumab plus ipilimumab. Lynch syndrome here, or something else. So it's really kind of good. And here, again, independent of financial reimbursement issues, this is what you could do if you had all the tools available. So, Tony, what do you think?
I mean, I think I already answered this one, and I would do Pembro or Nivo first for this patient.
So you already jump onto the bandwagon of outside of clinical studies. You don't need Howard's trial anymore.
No, I want Howard's trial, and Howard's trial would take precedence always. But off a trial, like I said, I mean, when you look at the data and you just compare across trials, of course, we need to have this answered in a clinical trial. But you can't argue with more than a 20% complete response rate, which is something you do not see with chemotherapy. Period. And some of these patients, I mean, they may never actually see chemotherapy, and we of course have to see long-term follow-up. But we look at the Dongli initial study with Pembro and MSI high. There are patients that continue to be responders 3 to 4 years after, although these were more refractory. But if anything, we learned from gastric, from Keynote 059, is these agents even work better when you move them up the line.
So I find interesting that pembrolizumab is being chosen, but not nivolumab. Is that, Scott, is there something, because we have data, including data on Nivo plus IPI.
I don't want to read the mind of those that answered Pembro, but I think when we do Pembro as opposed to Nivo, a lot of it is just scheduling, right? 3 weeks versus 2 weeks. So now it's going to be a little interesting because Nivo just got a 4-week supplemental BLA for almost all indications except for MSI, which was the one that was not on the list for inclusion. Now, it's hard to believe the insurance wouldn't allow you to do something less frequently. So it'll be interesting to see. I think we'll start to use more Nivo again just because of the convenience of the 4-week dosing.
Yeah, and you have Neil.
So we are going to have the data of the role of frontline PD-1 therapy compared to chemotherapy in first line, and I'm very optimistic about this data, but we're still waiting for the data to occur. But however, on the other hand, chemotherapy right now still has a higher response rate than single-agent PD-1s, either with Nivo or Pembro. And in a patient with symptomatic liver metastasis, you could certainly justify sticking with standard therapy here. And in this patient, I would start with FOLFOX.
Okay, you're jumping ahead because that's part of the next scenario. So, okay, let's skip over the next question because we have, for time issues, next because it was actually second line. So let's go to the next one. Sorry.
Can I just add a perspective? So, first of all, the trial is James Lee and Mike Overman, not me. But I think at this point in time, we still don't know how well chemotherapy works for these patients, and it can work very well. Like, I had a patient on the Pembro versus chemo trial, Keynote 77, who was on chemo with maintenance for 1.5 years and hadn't progressed, just anecdotally. But we just really don't know if you need to start with immunotherapy or even that's better than doing it sequentially. So I advise people to keep an open mind.
Yeah. So enroll in the clinical trial.
And
I think we
and
mentioned that.
Yeah, and the commit study also is looking at FOLFOX plus PD-L1,
Correct.
right? Which I think is another really interesting question.
Yeah. Okay, so case 2, and this kind of goes along the line what Neil already said, so now the same patient has peritoneal retroperitoneal metastases, so is symptomatic from the disease, and he's actually opioid dependent for his pain. So now, same question, what do you do? No, nothing else changed. Left-sided, Lynch syndrome, young patient, now symptomatic disease, and so what do you do? Same options, FOLFOX or FOLFIRI-Bev, an EGF antibody, FOLFOXIRI-Bev, Pembro, Nivo plus IPI or something else. Okay, Neil, is that reflecting what you think should be done? I mean, we see a shift toward standard chemotherapy more than before.
I think that's what I would do, is stick with standard chemotherapy. I usually don't use EGFR therapies right up front. I mean, there's different stylistic ways of approaching this, but chemotherapy combination, certainly I think is the standard and reasonable way to move forward.
No, I think the Pembro still looks the same. It was 21%, and the other one remains 21%. So those who buy into the PD-1 first are not selling. They're still buying.
So Tony, do we have any idea about the kind of the velocity of response or how rapid we see responses with PD-1 antibodies compared to chemo?
Yeah, so it is very interesting because you hear it all over the place. But I have to tell you, that from clinical experience, so I have to talk from clinical experience, I had the exact same patient, although a little bit older, with significant retroperitoneal disease, massive ascites, being admitted to the hospital every week. In fact, that patient had received chemotherapy first before she got transferred to our facility. And literally, I was having the hospice discussion when her tumor came back at MSI-H. Within 9 weeks, her CA was normalized, and her ascites was gone, and I can barely see any disease. I mean, the maximum response seems to happen after 24 weeks. That does not mean you don't see a good response earlier on. I think it's for some patients, the response is brisk and prolonged, and for others, it's not. I think you're never wrong if you go with chemo first, followed by PD-1, or vice versa. Most of these patients are going to be exposed to both. It's just a preference. I mean, for me, a patient like that could go for life without ever seeing chemotherapy. Again, we still want to wait for the long-term results, but that's my bias.
But I still want to highlight, what Howard said. I mean, we shouldn't waste the opportunity of really figuring out what's going on here, especially the sequencing of chemo followed by immunotherapy or combination. There's some data in gastric cancer which makes it interesting. So I think we need to clarify that before we start treating every patient with pembrolizumab, nivolumab, plus minus IPI, in first line. Okay, let's skip over the second line question again, because I want to move on to another. Okay, so number 3. Now we have a 64 female patient, a year-old female patient, ascending colon cancer, which you might recognize as on the right side. Now it's an MLH1 negative cancer, and we have a BRAF V600E mutation. So this patient has back pain, right upper quadrant pain, so it's a symptomatic cancer with a BRAF V600E mutation, MSI high due to methylation promoter region of MLH1. So a different cancer, the same hypermutated phenotype. So what do? Again, FOLFOX, FOLFIRI-Bev, you have a left-sided tumor. You have a BRAF mutant tumor, EGF receptor antibody, FOLFOXIRI with or without Bev, Pembro, Nivo, IPI, or you use the COPETS regimen of vemurafenib plus cetuximab or panitumumab plus minus chemotherapy. So very unanimous here. Okay. So so apparently your treatment was so convincing that everyone would use, the minority, but still a third of people would use vemurafenib plus combination. So what would you use in this setting?
Yeah, it's the combination regimens, I think, have increasing response rates, but the durability, as I mentioned, is something that we're still struggling to kind of reach that length of durability that we're getting with immunotherapy. So, you know, even the best data we have out there is kind of 8-month PFS now with the targeted therapy. So in these patients, and it's probably somewhere in the order of 15 to 20% of MSI that are BRAF or maybe 20 range, and then vice versa of the MSI or BRAF or MSI. So there is a bit of an overlap there. So this does come up. But in this situation, I would use actually this one I'd probably start with the triplet chemotherapy first, but then before going to the BRAF, probably trying to see if we can get a response with the immunotherapy as a next.
Okay, so you'd use number 3, and then you use
3, 5, 7.
3, 5, 7.
Yes.
Why not 3, 6, or 3, 4?
3, well, I guess you did say you
it's
don't
like
have to worry
ordering
about
from a Chinese menu,
reimbursements
isn't it?
or
Like 3.
financial, right? So Nivo now Q4 weeks, so we're going to be using more of that. So that's why not 4, using 5 instead. And then the doublet certainly does have, you know, anecdotally looks like, or by cross cohort comparison, looks better. So, but I think it's still just getting access.
But we also need to highlight, I mean, number 7, the Beacon study, which you promoted earlier today, I think is going to have a better BRAF inhibitor and a better biologic concept than the SWOG study. Would you agree with that?
Right. Yep. And that's where we're getting, you know, response rates up in the 40s and PFS extending out past 8 months.
Yeah, and I mean, I think here it's very important. I see there's a smattering of different answers, and as mentioned earlier today, none of these answers necessarily, you know, wrong. I think number 2 is probably the wrongest here, right-sided BRAF mutant tumor, which is the wrongest, the most wrong, whatever. But I do believe I would have used number 3, you know, a triplet if patients in good performance status, with or without bevacizumab. Probably with Bev here in order to have a reliable, relatively reliable tumor shrinkage activity. Okay, let's skip over the second line question again, and I think we have one more case. Okay, so now this patient here, same patient, but has no cancer-related symptoms. So again, we have a MSI high, BRAF V600E mutation positive, non-Lynch syndrome. The patient scattered unresectable disease, but no cancer-related symptoms, so we're not shooting for response necessarily. So let's vote again. And again, you've seen the answers. I said there's no real negative. Okay, good. I mean, I think we can leave it like this here. There's different options. So treatment of colorectal cancer will become more complicated.
Everyone's
and
right.
you know, you can see that the NCCN guidelines actually get thicker and thicker every year, and we're testing more and more biomarkers. And I think this is a great, fun topic to talk about. I want to highlight one point. I mean, which came up in some of the questions here: the toxicities of some of the regimens we talk about, in not just immuno-oncology, in just not PD-L1, but the CA, TCB, cobimetinib, atezolizumab. They are not trivial. So as much as we're excited about, you know, response rates in the range of, let's say, 20%, durability of response, we still need to learn how to work with these agents, because we don't want to be burned and discard something because we haven't learned how to manage toxicities. I think that's a very important point. Okay, any other last questions? We're right on time. Right on time, and, you know, thank you for the panel. I think thanks for participating.